everyone. Today's topic is BCG adenitis and why I have selected this topic, BCG adenitis, because recently there was a case of BCG adenitis in our OPD and I will present the case as such, how the case came, what happened to that child. And the BCG is widely given all over the world and WHO incorporated this BCG vaccine in Universal Immunization Program in 1974, although it was used first in 1921. And it is very widely used vaccines. And BCG is very safe. Adverse reactions are very few, but it happens. So we will know what are the adverse events and what is this BCG adenitis and how we should manage this case if this case comes to us. So 6-month-old boy visited OPD with mother. Chief and only one complaint was swelling in left axilla for last 2 months. The attending pediatrician prescribed antibiotics for 1 week. After 1 week, there was no response. Then the child was prescribed antibiotics for further 1 week. Now, after 14 days, there was no response and the mother noticed redness over the swelling. This time, the pediatrician took opinion of dermatologist. The dermatologist prescribed topical medicine and a further 1 week course of same antibiotic, that is amoxicillin. After 1 week, seeing no response, the dermatologist referred the case to surgeon because it was the swelling. So the dermatologist felt that surgeon opinion is required. So surgeon examined the case and noted pus collection inside the swelling, but seeked my opinion before going for incision and drainage. So when I examined the swelling, it was slightly fluctuant. BCG scar was not well formed, but it was given as there was point of a scar in the form of a small nodule, and mother confirmed that the child received BCG. To me, there was left axillary lymphadenitis with fluctuation. BCG scar was not well formed but visible. Child was fitting well, activities were normal for the age, growth and development was appropriate for the age. I requested for USG of the swelling just to confirm my finding, whether I am right or wrong. So USG revealed lymphadenopathy with suppuration. So I plan to aspirate it and send the sample for CBNAC and MGIT culture. MGIT is Mycobacterium growth induction tube, which gives results in almost 3 weeks. So CBNAC came positive for mycobacteria with sensitivity to rifampicin. Culture and sensitivity report is awaited. Will come after 12 weeks as told by laboratory. So now what should we do? Management of this BCG adenitis is controversial all over the world. That's why I searched so many literatures and extracted something that is didactic things. You will not have to go and search with different literatures and recommendations. I have done it for you people, and this is called didactic, and we'll know what we'll do. I just reassured the mother about the swelling that it will subside automatically and asked her for monthly follow-up visit in OPD. Reason why I have advised this, what is the reason behind this, behind my advice? The child was asymptomatic, the swelling was noticed by mother, the child was thriving well, there was no known contact with adult pulmonary tuberculosis, no family history suggesting any primary immune deficiency. So there are certain things in history which can suggest primary immune deficiency in the family, like death of siblings in early age, death of relatives of mother or father in early age. So it was not there. Nothing was suggestive of primary immune deficiency in the family. So this is important, and I will explain why this is important. This history is important in case of BCG adenitis. So what is normal BCG reaction? A papule develops at the site of inoculation at 6 to 8 weeks approximately. It increases in size, ruptures and heals by approximately 10 to 12 weeks, and a scar is formed which remains for whole life. This scar, and it is a general agreement to give the dose at left arm, although it can be given on right arm also. And in one case, I have also given in thigh because on the request of a mother who was gynecologist, and she requested me, I don't like this scar on the arm, so please give on the thigh. So it should not be given, but customarily, and it is general agreement world over to give this at the left arm. So 0.1 ml of vaccine is given intradermally, which contains live attenuated Mycobacterium bovis, and the most commonly used, there are so many strains, but most commonly used strain is Danish 1331. So approximately 100 million newborns are given this vaccine per year worldwide. The efficacy of vaccine is variable, means it varies from 0 to 80%. 0 means it may not be effective in some children, 0%, and it may be also 80%. So this is recent. It's कुछ चीजें चेंज नहीं होती हैं सर. नहीं देखिए अब आप नहीं, इसका डेनिस 3031 जो यूज हो रहा है उसका भी यही है. तो इसका एफिकेसी अभी जो यूज हो रहा है उसका ज्यादा है. I will come over this disseminated disease. I will describe everything. So the main role of BCG vaccine is to prevent disseminated tuberculosis and tuberculous meningitis in infants and children. So its efficacy for prevention of disseminated tuberculosis is 78%, and for prevention of tuberculous meningitis is 64%. So this is very good in preventing this disseminated form of the tuberculosis and tuberculous meningitis. So what may be the adverse reactions of BCG? BCG is a very safe vaccine being used worldwide. Adverse reactions worldwide ranges from 0.5 to 100 per lakh recipients. The most serious adverse reactions is disseminated tuberculosis, and it occurs in less than 1 in a million recipients. The most common adverse event is lymphadenitis, and it is called BCG adenitis or BCG lymphadenitis. BCG adenitis may be of two types: non-suppurative BCG lymphadenitis and suppurative BCG lymphadenitis. So it is diagnosed clinically. There is no need for any investigation to diagnose this case, BCG lymphadenitis. So it is diagnosed when the lymph node, usually axillary lymph node, enlarges on ipsilateral side, means on the side in which BCG vaccine has been given. So it becomes marked and noticed by parents when size becomes equal to or more than 1 centimeter. Then it is visible and it is marked by the parents and parentic consultation usually. So it usually appears at the age of 2 weeks to 6 months if the child is vaccinated at birth. So some child may not be vaccinated at birth. Some children will receive this vaccine after 1 month, 2 months, like that. So it may appear till the age of 24 months. This is important. It may appear, this BCG adenitis may appear till the age of 24 months. In most of the cases, it develops after 2 to 4 months of vaccination. Means, if the child has received at the age of 2 months, at the age of 4 months, so this is relevant for those children. There should not be enlargement of lymph node of other side, and there should be no tenderness at the lymph node. And distant lymph node enlargement or organomegaly should be absent. So there should not be enlargement of the distant lymph nodes like other side lymph nodes and inguinal lymph nodes. And there should not be any systemic manifestations in the form of fever or failure to thrive. So in our case, there was no systemic symptoms. There was no failure to thrive. Child was thriving very well, as I have described in history. And the most commonly involved lymph node is axial lymph node. Rarely, cervical or supraclavicular lymph nodes may be enlarged ipsilaterally in addition or in isolation. Means there may be enlargement of axillary with cervical and supraclavicular, or there may be enlargement of only cervical or only supraclavicular. So there may be enlargement of more than one ipsilateral lymph nodes. There may be enlargement of more than one, means multiple axial lymph nodes, involvement of cervical lymph nodes, involvement of supraclavicular lymph nodes may be there. So these all will constitute BCG lymphadenitis. So what is disseminated BCG infection? It is also called BCG oocyst or disseminated BCG disease. So it is the most serious complication of BCG because mortality occurs in one case per million of recipient of this BCG vaccine. So this is the most serious complication of BCG vaccine, although it is not common. And it is seen in children with primary immune deficiency like severe combined immunodeficiency, chronic granulomatous disease, complete withdrawal syndrome, and MSMD. MSMD, what is this MSMD? Just I would like to describe something about this MSMD. What is this? This is Mendelian susceptibility to mycobacterial disease. So what happens? There are some populations in the world in which there is defect in interleukin 12 and gamma interferon system. So as we all know, there are two types of immunity, innate immunity and adaptive immunity. So the first comes is innate immunity. So in tuberculosis also the first defense mechanism is activation of macrophage. Activation of macrophage, then comes cellular immunity. So after activation, for the activation of macrophage, there is required so many cytokines and chemokines. So after granuloma formation, there is release of chemokines and cytokines, and the important cytokines are spectra alpha, interleukin 12, and gamma interferon. So there are some populations in the world in which there is deficiency of gamma interferon 1-2 receptor activity. There may be deficiency of interleukin 12, 23 beta receptor activity. Apart from this, there may be deficiency of STAT1 and demo. So these all constitute MSMD, means Mendelian susceptibility to mycobacterium disease. What happens in these populations? There are recurrence of these infections and treatment is very difficult. Very difficult means you will prescribe antimycobacterials which may work, may not work, and works for a few months. Then again there is resurgence of the disease and treatment may be required for years together. So this is MSMD. So it may be seen in secondary immune deficiency, means disseminated BCG infection may be seen in secondary immune deficiency also, like AIDS. So it is suspected when, how we suspect it is disseminated BCG infection or disseminated BCG disease or BCGosis. So it is suspected when there is fever, not gaining weight by the child, and hepatosmegaly, enlargement of the distant lymph nodes in BCG vaccinated child, cutaneous lesions or abscess beyond the region of vaccination. It is diagnosed by detection of Mycobacterium bovis by culture of the organ involved, and histopathology will reveal granuloma formations, and there may be requirement of CCT chest or abdomen according to the site of involvement. So for the diagnosis of this disseminated TB, we require these things. So what are the factors related to adverse events? Factors may be quality subcutaneous inoculations. It is common because intradermal injection is a difficult thing. If you have given intradermally, I have given intradermal BCG, it is some force will require. Sometimes will not able to go intradermally, you will give subcutaneously. So this is the one factor. Faulty technique means you have not given intradermally and it has gone subcutaneously. Second is higher dose of administration. So recommended dose is 0.1 ml and in inoculation you may give 0.2, 0.3, 0.4 ml like that. So third is residual virulence of the vaccine strain. Some virulence may be there in the vaccines which may cause these reactions. And this is very important, quality storage conditions. Means cold chain maintenance is mandatory. If you are not maintaining this, then faulty storage condition will lead to adverse events in the form of these. And other factor is primary immune deficiency, which I have already described. So what are the management guidelines? What guidelines says? After going through these guidelines, we will know I have done right or wrong for our child. So for non-suppurative lymphadenitis, it usually resolves within 4 to 6 weeks. But our case was suppurative lymphadenitis. Ultrasound suppurations and some GG material came in the aspirations, which was sent for CBNAT and MGT culture. So our case was not this. So non-suppurative resolves within 4 to 6 weeks. Just parents should be reassured that it will subside. But follow up the child regularly for the development of any symptom in the form of fever, not gaining weight, and look for the evidence of any PID in the family, which I have already described. What history we should get so that we can suspect that there is history of primary deficiency in the family, and we should elaborate the history and investigate properly for that. And most importantly, motivate the family for continuation of immunization. What happens if there is reaction to any vaccines? Family refuses for further immunizations because their parents say that it is dangerous, it is harming my child. Why should I go for other immunization? So this is very important counseling for parents. So what to do in suppurative lymphadenitis? There may be development of fluctuation, erythema, and edema on the swelling. In case of suppurative lymphadenitis, suppurative lesion usually ruptures, a sinus is formed, and healing occurs after delayed period of time. Healing occurs automatically, but after a delayed period of time. So it leaves a very bad scar, which is not acceptable cosmetically. Cosmetically, it looks bad. When it itself ruptures and heals after a delayed period of time and gives a scar. So the treatment is aspiration, not oxygen. Aspiration. So it should be aspirated, and there may be a need of repeated aspirations. Because one time you will aspirate, there will be collection, then another time you will have to aspirate. So oxygen should not be then, it should be aspirated, because oxygen also gives ugly scar and it requires general anesthesia for the children for the oxygen. So we will know when oxygen will be done. So the treatment is repeated aspiration, and the most important thing is there is no role of antituberculous drug. Previously, antimicrobial drugs in the form of azithromycin, erythromycin were being used. Antituberculous drugs were being given to treat this particularly suppurative lymphadenitis. But nowadays, it has been observed in various clinical studies that it automatically subsides. There is no need to give any antimicrobial or antituberculous treatment. So when surgical excision is required, if the size has not regressed even after 6 to 9 months, and it is
अच्छा ये भी भरना है ये मैडम किस तरह तो किस कॉम्पिटिशन से पड़ा हुआ है तो जमा होता है ना इसमें वहाँ पे करके जमा होगा ना ये पिछले साल का तो जमा होगा इसको तो इस साल का दिन होगा ना 2022 का अब इस तरह की बात देखते हैं बात करो। ये भी बवाल है अरे करके इसके के टाइम पे मैंने अभी तक तो होली का इवनिंग कर रहे हो तो वो मॉर्निंग करने को मॉर्निंग डॉक्टर ने दी मॉर्निंग शाम करना नहीं चाह रही है तो फिर कल भी सकती है तो कल साथ ठीक करते हैं चल रहा है ठीक करते हैं इवनिंग में आते हैं बाकी मॉर्निंग तो लोग देखेंगे अपना नहीं आज से करो ना आपको लेना आप ले लो मैं ले लेता हूँ आप भी ले लो आप मॉर्निंग कर रहे हो ना नहीं परसों हाँ तो कल ये कर देंगे ना कल ये आप जो करोगे आप देख लो अभी पड़ेगी तो ले लूंगा बता तो रही तो आप ले लीजिए मैं आ जाऊंगा घर तो जाना होता नहीं इधर आ जाता हूँ ये 100 वर्ड बोला इन्होंने लाइफ वालों ने वहाँ पे यूनिवर्सिटी पे कल हाँ होली परसों छुट्टी होती कल भी थोड़ी होती हाँ है वैसे
पंकज ने कार्ड नहीं भेजे तो आप लोगों को कहाँ गया ग्रुप में से आपके इसका एक लिस्ट भेजिए
हाँ हाँ वो तो पड़ा होगा
तो सर उसी में पता चल जाएगा आपको हमें तो दूसरा से पूछने की जरूरत नहीं
आपके पास है वो कार्ड
ग्रुप है